So hello, my name is Dr. Ukiri Richard. On our basic cardiology podcast today, we are going to talk about ICD and rapid heart rates. A 61-year-old patient was brought into the hospital through the emergency medical care because he has been having rapid heart rate persistent for 1.5 hours. He also had associated shortness of breath and palpitations. From his medical record, you saw that he has an ICD implanted actually as primary preventive measures, only a history of ventricular rhythm disturbance, but because of significantly reduced left ventricular function and a history of myocardial infarction. When the patient was asked if he felt any shock from the ICD, he denied it, and he never had a syncope or fall. The blood pressure was 95 to 65 millimeters of mercury. The heart rate was 169 per minute, and the respiratory rate was 16. What are the first step you will do, and what test will you request for? Well, the first test I would do is to order for a blood test and an ECG immediately. Okay, you did the 12-channel ECG and you saw a tachycardia with wide QRS complex. The heart rate was 169 per minute. There were no pacemaker stimulation. The axis was atypical one, overturned right axis with possible P waves. Don't forget that it is very difficult sometimes to differentiate a supraventricular tachycardia that has wide QRS complex from a ventricular tachycardia. There are different algorithms in different literatures, but a definite differentiation in 12-channel ECG is very, very difficult. The important ECG differential diagnosis in wide QRS tachycardia, that is differential diagnosis to ventricular tachycardia, are 1. Supraventricular tachycardia with bundle branch block like sinus tachycardia, atrial fibrillation or atrial flutter, focal atrial tachycardia, AV node reentry tachycardia, autodromic tachycardia with bundle branch block like Wolff-Parkinson-White, autodromic tachycardia from Wolff-Parkinson-White, supraventricular tachycardia with pre-excitation across the accessory pathway like Wolff-Parkinson-White, and a stimulated rhythm. But the important criteria that support a ventricular tachycardia are 1. VA atrioventricular dissociation, which is confirmatory for a ventricular tachycardia. 2. When there's a fusion beat, that is simultaneous depolarization of the ventricular myocardium through the specific conduction pathway and through that from the ventricular focus. Then an atypical axis, where there is absence of typical right or left bundle branch block configuration. Okay, let's come back to your patient. Your patient was connected to a monitor. The vital parameters still remain unchanged, and your patient was fully oriented and stable. How will you determine if and which emergency measures you will take as your next step? Well, I have a table here that I will go to read to you. If you have a ventricular tachycardia and the patient is stable, you use medications like amiodarone intravenously 150 milligram over 10 minutes, maximum of 2.2 gram in 24 hours. You can plan an elective electrocardioversion, and in patients that already have ICD, you can do a manual overstimulation. But in patients that are unstable here means there's a reduced consciousness with dizziness, there's systolic hypotension below 90 millimeters of mercury, and they have thorax pain, then you do an immediate electric cardioversion. So in this case, you decided that the patient is a hemodynamic stable, so you do not need an immediate external electrocardioversion. And see, since you already had an ICD, you look for somebody that has experience with the care of ICD aggregation to help you with the overstimulation. Okay, the person came and tried to read the ICD store. He saw multiple episodes of slow ventricular tachycardia, mostly under the programmed detection boundary, which was 170 per minute. That's the monitor zone. The pacing and sensing were in order. The threshold were also in order, and the impedance okay. But you saw that the ventricular rate was higher than the atrial rate, which confirms the ventricular tachycardia. After reducing the ventricular tachycardia zone to 160 per minute, he was able to terminate the ventricular tachycardia through an overstimulation. So after the overstimulation, you wrote an ECG to document the new findings. So the ECG was brought to you. Now this time you found a sinus tachycardia with a rate of 106 per minute. Your axis was now an overturned left axis, and T wave negativity were seen in 1 AVL as well as V3 to V6. Now your laboratory results also came, which actually had normal findings apart from a slightly elevated blood sugar, which is random sugar actually. But especially CK, CKMB, troponin were all normal. So what you additionally did here is to send or to request for previous medical records, and you got this information that the patient has a 3-vessel disease, coronary 3-vessel disease with reduced left ventricular function due to an ischemic cardiomyopathy with ejection fraction of 29%. He had a back wall myocardial infarction 10 years ago. He also has had multiple coronary intervention and stenting, but he did a coronary angiography 2 months ago that did not show any progression in this disease. He had the implantation of the ICD, which is actually a 2-chamber ICD, a year ago as a primary prevention method. He's a hypertensive patient, has hypercholesterolemia. He used to be a smoker. He has chronic obstructive pulmonary disease, gold stage 2. And you saw an old ECG that does not have any change compared to the one you have now after the overstimulation. My question is, since the patient has a coronary heart disease, are you thinking of doing an invasive left heart catheterization? Please explain what you base your decisions on. Well, in this case, I would not do a coronary angiography. My decision depends on the following factors. 1, the patient is presently symptom-free, and the ECG we have does not show any change compared to previous ECGs. The coronary angiography that was done 2 months ago did not show any disease progression, and the laboratory findings did not have evidence of coronary ischemia, despite the fact that the tachycardia lasted for 1.5 hours with a high ventricular rate. I will admit the patient for monitoring and optimization of the medications as well as other ischemia diagnosis, ischemic tests. Okay, the next question: what therapeutic options do you have in case there are future recurrence and with increased frequencies? Well, it's either I expand the antiarrhythmic therapy, for example, additionally administration of amiodarone, or you can consider catheter ablation. Thank you very much.